Hello and welcome to our monthly teleconference series. Today's topic is heart health, brought to you by Northern Westchester Hospital. My name is Margaret Robato and I'm a registered nurse and nurse educator for the Community Health Education and Outreach team. I would like to introduce Dr. Craig Basman, MD, FACC. He's an interventional cardiologist, structural interventionalist at the Sima Boski Heart Center here at Northern Westchester Hospital. In addition to this position, Dr. Basman is an attending physician in the Department of Cardiothoracic Surgery at Lenox Hill Hospital. Let's get started with the presentation. Welcome, Dr. Basman.
Well, thank you. Thanks so much for having me today. It's really great to be here, and I know how much time and effort you put into this educational outreach, and I think it's a fantastic initiative. Great way for us physicians to kind of connect with patients and kind of, informally discuss healthcare goals outside of scheduled appointments. And certainly in this day and age when people don't want to leave their house, I think it's a thing that our field is lacking. So congratulations to you for really kind of, spearheading this initiative.
Thank you. That's exactly our hope. I appreciate that.
Yeah. So again, I'm an interventional cardiologist and a structural interventionalist at Northwell Health. I have a dual role at Northern Westchester Hospital where I do most of my cardiac procedures, and also Lenox Hill Hospital, part of the cardiothoracic surgery team, where I do some of the more complex and unique high-risk cases. So I'm here to talk about the field of interventional cardiology today, and really what we're doing to not only prolong survival, but improve quality of life. Many of you know that heart disease is the #1 cause of death worldwide. And the majority, when you talk about death from cardiac causes, is due to coronary artery disease, or CAD. What coronary artery disease is the buildup of plaque in the coronary arteries, which are the blood vessels that supply the heart. Over time, you get this buildup that causes decreased blood flow. And so blood flow to the heart becomes diminished. And then you have sequelae of that. Things like angina, which is chest pain, congestive heart failure, and dangerous arrhythmias are all things that are kind of feared complications once the heart lacks blood supply. So also occasionally we see that plaque, which accumulates in the coronary arteries over time, can rupture, causing a heart attack. And heart attack, as we all know, is associated with poor survival, and especially without timely intervention. Thankfully, our field has really evolved over the years, and actually started with a guy named Andreas Grunzig, who was really the first to perform percutaneous coronary intervention, or PCI, which is essentially a way of fixing blockages in the heart without needing open heart surgery. So that was back in 1978. And the whole concept was to take a catheter, insert it through the blood vessels in the groin, which lead up to the heart, bring it up to the coronary arteries, and then use equipment to kind of fix the blockages in the heart and in the heart arteries and give blood supply back. And since that original PCI, the whole field of interventional cardiology has been driven by remarkable technological advances. And we have smaller catheters. So back in 1978, we're talking about a bigger equipment going through the groin arteries, and now we have ways to go through the wrist arteries. We have drug-eluting stents, which are basically used to prop open the blockages and keep them patent over the next 10 years plus, and then adjunctive devices to kind of debulk heavily calcified arteries. So a lot of people have a lot of junky plaque in their arteries, and there wasn't much that we could do before, but now we have treatments like laser and drills called rotational atherectomy we can use to kind of debulk these arteries, and then we can place stents in them to keep them open over time. And if you look at all these advances, they've resulted in not only great acute procedural success, meaning that 99+% of the time we're going to be able to have a successful procedure, but mortality is insanely low, especially with elective procedures, less than 0.1%. And we have better long-term outcomes where the majority of stents are lasting more than 10 years. So people who are getting them in their 50s, those stents can stay open for the rest of their lives. And some of the, occasionally at 10 years, maybe less than 5% need a tune-up, and we have, the capability to do that as well. So, along with all these technological advances, you have to kind of credit our pharmacology, in that we've had improved adjunctive pharmacology with the introduction of kind of newer antiplatelet agents that, we take after stents or to prevent heart attacks and help reduce the rate of recurrent heart attacks and also stent failure. And then, technically, as I said, we're getting much better at reducing the morbidity of the procedure. Right now, we're using small catheters. Most of us at Northern Westchester will go through the wrist. The majority of, actually all of us go through the wrist. The majority of the times, there are select cases where we need to use the groin. But, this is kind of reduced bleeding complications. We do it all with just a little bit of conscious sedation. It's not a painful procedure. Give a little bit of, analgesics just for patient comfort, and maybe a little anti-anxiety meds. Put them on the table, and generally the procedures are less than an hour, with the length of hospital stay that's less than one night if we need to fix something. So after the procedures, people are up, they're out of bed within, especially if we can go through the wrist, within the hour, walking around, able to eat and talk. And now we're even, selecting patients to send home that day after they get their stent, to keep, hospital rates down, in the era of COVID. So, just to talk a little bit about what we're doing at Northern Westchester, I think that over the past decade, we recognized this barrier preventing good clinical care, top clinical care within our health system. And that's that if you look at last year alone, our institution at Northern Westchester Hospital had over 250 cardiac emergencies that were diverted to an outside cardiac catheterization lab. And, when we were looking to open this cath lab, we were using this data to show that, well, not only are we diverting all these cases, but there's actually good data, medical data for over the past 25 years showing that these emergency cases would benefit from early access to a cardiac catheterization lab. Because, the common quote with heart attacks is, well, time is heart. So therefore, we felt that it was our responsibility to serve all these patients with the highest clinical care. And that's really what pushed us to implement this cardiac catheterization laboratory, which obviously needed a little help on the finance side. And that's where Seema Boski was able to, really generate some of that money to open the cath lab just out of the kindness of her heart. Since the opening of our cath lab in September, I think we're on pace for over 1,000 cases a year. And, many of those cases are potentially life-saving procedures. So, for one thing, the convenience of, people in the community able to go to their hospital. But another thing is that, if someone's sick in the hospital, it's not nice for the families to travel to New York, to Danbury, or wherever it is, to see their family, where now we have it right here. We have everything you need right in our cardiac cath lab at Northern Westchester Hospital. And I think, I'm very fortunate to be one of the 5 doctors to help spearhead this movement, and I have to name a couple other people just to give credit where credit's due. And I'm going to talk right now. I'm just going to name 3 other doctors that were really instrumental. And that's, Carl Reimers, who's, my partner and the director of the cath lab. He's been doing this for, 20 plus years. And, he's really set the tone as one of the leaders in how we're providing top clinical care and giving all these patients what they need. Varinder Singh, who's the chairman of the whole Western region for cardiology at Northwell, he's at Lenox, he's at other institutions all over. This guy comes to Northern Westchester Hospital because he loves it so much. He's there every Friday from morning until night, and in various times through the week, checking on things. He has patients that are there. So, he's been really instrumental in opening this whole cath lab. And then Jack Catanese, who's the chairman of cardiology at Northern Westchester Hospital. So he's, been pushing for all this to open for years. And finally, Jack got exactly what he needed, which is his interventionalist coming right there. So I think that, it's been really privileged to help this wonderful community. And I'm really grateful that the whole hospital's rallied alongside us to provide this top-notch care. One of the unique features of this lab is its collaboration with the team at Lenox Hill. So, it's an extension of Lenox Hill Heart and Lung, which if you look at Lenox Hill, it was actually in 1938, the first place in the United States to perform a cardiac angiogram. And then in the late 60s was the first one to actually open a cardiac care unit. So Lenox has kind of been at the forefront of everything. And I think that what's really beneficial is that we have access to a cardiac surgeries team from Lenox Hill, which is the #1 cardiac surgical program in the whole of New York. So, one of my roles is to kind of bridge this population with the cardiac surgery program at Lenox Hill Hospital. And, we have access to them 24/7. So one of the things that we're seeing is that as our population's aging, the prevalence of heart disease is increasing. And that's because, one of the major risk factors for heart disease is age. So all these patients may not actually be good for, not every patient is a good candidate for heart surgery. And that's why our evolution of transcatheter technologies has been so essential. So while we've been getting better and better at placing stents throughout the year to where I've told you we're at now, where 95% of the time these stents last greater than 10 years. There's other issues as well, and especially in the octogenarian population, where we have valvular heart disease, which is ubiquitous, and we also have to worry about these issues too. And it all begins in the cardiac cath lab, because all these patients end up in the cath lab. You need to check the arteries, you need to check the valves, and this is, the gold standard place to check all these things. So what we see here is that, as, the heart valves age, there's increased degeneration. And in the past, we had, treatment options were really just open heart surgery. But as transcatheter technology has evolved, we're now repairing and replacing major heart valves without any open heart surgery technique. And that's a technique like TAVR, which is transcatheter aortic valve replacement, going through the groin, similar to how we do a cardiac catheterization, which has really revolutionized the field of interventional cardiology. Safe, just as safe and effective as open heart surgery. And then on top of that, it's a one-day hospital stay with immediate return to function. So, really kind of an interesting time to be in the field of interventional cardiology, and the things that we have access to at Northern Westchester, I think is quite remarkable, especially compared to where we were last year. And then, before I know that, we'll open it up for some questions, but lastly, I just wanted to talk a little bit about COVID and how it's kind of impacted our practice in terms of the heart perspective. Because I think that, one of the major issues of COVID is not just how many deaths it's caused directly, but we've seen countless patients neglect their health care, specifically heart health, over the past year. And a delay in care has really led to progression of heart disease. And we've seen common cases where all these patients are more afraid to go to the hospitals from COVID than actually dying from a cardiac condition. So, since we reopened elective surgery and as COVID's kind of calmed down, we're frequently encountering these patients that have waited too long and are either left with debilitating issues such as congestive heart failure, or some of the patients we never got to see because it was too late. And I urge that, anybody listening, anybody on the line, let's not neglect our own heart care, because being safe is not just about putting on a mask, but it's part of but being safe is also, taking care of your own body. So, that's a little bit about interventional in the current era. But I know you wanted to ask some questions and open it up a little bit for more of a conversation, so I don't feel like I'm talking everyone's ear off.
Well, thank you so much, Dr. Basman. It's such hopeful and good news between the new technology and the drugs and our association with Lenox Hill Hospital. We really have had some great improvements to our opportunities to serve our community. So thank you for the work that you're doing. So some questions for you. What are my risk factors for heart disease?
So that's, I think it's a really good question, because, prevention is really where the field is headed, meaning let's get people to not be in the cardiac cath lab. So when it comes time to taking care of your own heart, and as I was saying before, take care of your heart, urge people to take care of your body. It starts with general health, and things like cholesterol and blood pressure are two of the main things we know about that we have to be controlled for heart care prevention. And fortunately, these are two things that can be, easily cared for. So you can go to your primary care doctor, check the cholesterol. It's recommended every year, past a certain age. The blood pressure. Now we have ambulatory blood pressure monitors. So those patients who, always say, oh, my blood pressure is elevated when I see the doctor because I get nervous. Well, we have kits and machines to check it at home. So staying on top of those, I think is the number one thing that we can do. And then obviously, exercise and diet's very important as well. Because we notice that the more sedentary people are, the more at risk they are for not just heart disease, but medical issues. And keeping the heart rate up, get it going on a walk, a jog, whatever it is, and moving around is associated with better outcomes in the long run. Diet's an interesting thing. And I have, especially a hard time thinking that maybe, an extra candy bar or an extra piece of red meat makes a difference when you're in your 70s or 80s. But I do think that these are kind of habits for younger people that are essential, because that's when the plaque really starts, is when you're in your 20s and 30s and 40s. So, exercise and diet, we have to, encourage. And I think the younger you start, the better it is, because as we move forward in our lives, I think it has less and less of an impact. And then the other two risk factors, I guess, I have to kind of mention are really unfortunately not preventable. And one of those is family history. So people who had a father, a mother that had heart disease early on in their 40s and their 50s, those are the people that are highest risk for having heart disease of their own. So family history is the best predictor of your own heart. And then the last thing is age. And as I said, as we age, our heart ages too. And that's why screening, especially as we get to our middle age, is so important to start to pick up this heart disease and help prevent plaque.
Okay, terrific. Great information. How do I know if I'm at risk for heart disease? For heart attacks.
So heart attacks the problem with the heart attacks is they're very unpredictable. And that's why we can't, to tell anyone that they're at risk for heart attack is really just what is your chance of having a heart attack. And the only way we can really prevent heart attacks is, well, we can't prevent it, but is to reduce the chance of it. And I think that the only way we can do that is preventing plaque buildup. And that all comes from risk factor modifications. So routine screening with stress tests is one thing that, we've been, does that help? And it's never really shown to be helpful, but there certainly are people that may benefit from a stress test. And now we have actual imaging to quantify and characterize the plaque in our heart with multi-detector cardiac CT. So, CT is a way that can give us anatomical information of the coronaries. And this can really help us, in how aggressive we need to be to reduce the risk of heart attack.
Okay. And what are the warning signs or symptoms of a heart attack?
So, traditionally you think of chest pain as being the main symptom for heart attack, but there are certainly other precursors to heart attack. And oftentimes we see that patients with coronary artery disease don't have chest pain, but other things, shortness of breath, not feeling well. Sometimes people with heart attacks present with, kind of epigastric discomfort and nausea. So, there's certainly different ways. I think that that's why we have to kind of get to when you have these atypical symptoms, maybe a little discomfort in your chest, maybe some more shortness of breath when you walk. That's maybe an indication that perhaps we're beginning to have advanced coronary artery disease. And those are the people we need to kind of screen to see if they have plaque, to see if they need an intervention. But typically, the textbook symptoms of a heart attack is what? Substernal chest pressure, that it feels like more of a pressure than a pain. And people describe it as kind of an elephant sitting on the chest, but that's not what we're seeing all the time. And some people have definitely atypical symptoms. So I think that once you feel, things that are not normal, that's when we need to get it checked up. And we have to keep it in our differential as doctors that, not everyone with heart disease presents with chest pain.
Okay. Right. Good to know. So, what are ways to prevent a heart attack if I am at risk?
So as much as what we do in the cath lab is opening arteries, fixing blockages, but it's never really shown to be a way to prevent heart attacks. It can treat heart attacks and it can prevent from sequelae, but it's always been very tough to prove that it actually prevents a heart attack. So the question is really, how do I not get on the cath lab table? And I think that comes with kind of risk factor modification. And then for those patients that we suspect advanced disease, those are the people that we need to revascularize, meaning fix the arteries. And that may be with stents, that may be with bypass surgery. But I think in terms of preventing a heart attack, the best, in those patients that are at risk, we as doctors need more aggressive screening with stress tests, with cardiac CTs and things like that to help pick this stuff up early so we can treat with either medicines or more invasive options to help prevent these people from having heart attacks.
Okay. And what is a cardiac stress test? When should I have this?
Well, a cardiac stress test is, I think it's the best way to think of it is kind of the gatekeeper to the cardiac cath lab, whereby, we have different types of stress tests. There's ones that we do with an echo. There's ones with a nuclear scan that requires a little radiation. And there's ones that are EKG and just EKG monitored, and they all have their own pros and cons. But, part of being a good physician is keeping people from the cath lab that don't need to be there. Because there's a lot of people that have chest discomfort, that have shortness of breath, but that doesn't mean that we need to put them all on the table. If we put everybody on the cath lab table, then we're bound to have complications, because the cath, as well as it goes 99% of the time, there's still a risk of something bad happening. A stroke less than 0.1% of the time, some bleeding. So certainly, these things like stress tests can really be a gatekeeper for patients to get them not into the cath lab, but keep them out of the cardiac cath lab.
Mhm. Okay. And when would I need a cardiac catheterization and/or stent?
So, I think that, a lot of the focus on this cardiac cath lab was, initially, we need this because people in the area that are having an emergency, be it heart attack or just new worsening angina that's severe, those are the people who benefit from not just an early cardiac catheterization, but also a stent. So, we know that in emergency settings like heart attack, that needs to be done soon. That needs to be done as fast as we can. And the best way to fix that is with a stent and, in occasional rare instances, bypass surgery. But there's also, a lot of people that most of our cases are elective, before it gets to emergency points where, and those are kind of the people, obviously people that are having chest pains when they're walking and it's getting worse. Yes, the stent's probably going to help you and make you feel better, but there's also other people with different types of symptoms, be it shortness of breath or just this vague discomfort. And that's where we can kind of use our stress test to help weed out who is the people that may have blockages, bring them to the cardiac catheterization lab. And then from that point on, it's up to us interventional cardiologists to determine if you need a stent or not. Because if I were to put 10 to 80-year-olds on the table, I'm going to find blockages. The question is how bad is the blockage? Is it a blockage that needs to be fixed? And what's the risk benefit of fixing it versus leaving it alone? So, we've pushed at Northern Westchester ways to guide these strategies. So we're not just implanting stents that aren't doing anything, meaning we check pressures to see how the pressure is before the blockage and afterwards. We look at the morphology of the plaque to see if it would be a high risk plaque that could cause heart attacks in the future. And those are the lesions that we're targeting, rather than just any blockage, because as I said, it's an easier procedure. We can put in a stent, but the question is it the right thing to do? And I think that's where our system, and specifically our interventionalists, have really done a good job of differentiating ourselves from other institutions where maybe they're a little bit, it's a little quicker to throw in a stent.
Right. Good to know. How has the Northern Westchester Cath Lab improved healthcare among the community?
So I guess until September, since September, up until September, those patients around the area who needed a cath lab were taken to Valhalla, New York, Danbury, Stamford, and I think that one, for emergency sakes, this eliminates a lot of time. So the data that we have is that when you have a heart attack, you need to fix it within 90 minutes. And after that sort of period, the outcomes get worse. And the state tracks all this stuff too, to see how you're doing in efficiency. And fortunately, we've done a very incredible job of getting to these heart attacks quickly since the opening of our cath lab. But before we had this, then it was, well, these people with heart attacks, let's get them to the to a near facility and stent it as quickly as we could. But you're looking at more than 90 minutes for that. And that's, when outcomes start to get worse. So I think that, from an emergency standpoint, it's really improved the outcomes for anyone locally that's had heart attacks or, major cardiac events. But also, in terms of a community and being with your loved one when they're going through a procedure. I'm certain if you're living in the Mount Kisco and the Bedford area, probably much easier for families, especially in this era, to take care of their significant others, their family, their fathers, mothers, or whoever it is, at Northern Westchester Hospital than it is to send them somewhere else and have to commute there and speak with those doctors. So yeah, I think that it's done a lot in terms of, convenience for the community, but also safety.
Yeah, very reassuring.
Yeah.
What is the best treatment for people with coronary artery disease or blockages in their heart arteries?
So as an interventionalist, what I do is percutaneous coronary intervention, which is stenting. But as I kind of mentioned before, we also have access to cardiac surgery. And, the cardiac surgical program at Atlantic Hill is the number one in the state in terms of their outcomes. And it's under the directorship of Dr. Jacob Scheinerman, who's a really, not just an excellent doctor, but a really excellent human being. And, if it's one blockage, we talk, we give you a stent. But as the blockages increase and it becomes harder to put in stents, that's when we talk about bypass surgery. And that's when we talk to Scheinerman and the team at Lenox Hill for their expertise in bypass surgery. And obviously, nobody wants to have their chest opened, but at the same time, outcomes are very good in the right patients. And the long-term effects of bypass surgery are probably superior to stenting. So if you have one blockage, it's no question, you're going to get a stent. You'll do great, I'm sure. But as it gets to more complex disease, that's when bypass surgery becomes an option. And, I think I credit the whole Lenox Hill team as a team that's not able to really kind of reduce the invasiveness of what's a pretty invasive procedure. And I think it's led to excellent outcomes there. So, a stent isn't right for everybody. And in fact, bypass for, multiple blockages or complex blockages, oftentimes it is the way to go.
Okay, great. As we age, what other issues should we worry about relating to the heart?
So, as an interventionalist, they call me kind of we're called the plumbers of cardiology, but there's also electrical issues. So we have electricians too, the electrophysiology docs, and thankfully we actually have implemented an electrophysiology doctor at Northern Westchester Hospital who puts in pacemakers, who does defibrillators on a daily basis. Nico Skipateris as well is one of the doctors that comes to Northern Westchester Hospital for all the electrical issues, because as we age, we go into our heart conduction ages too. So people, some people may have too slow heart rates. Some people go into what's called atrial fibrillation. And these are all kind of things we need to kind of check in, because sometimes some of these arrhythmias like atrial fibrillation, which, give you more of an increased risk of stroke, can be undetected, meaning patients don't feel it. So it's especially kind of important that we get our physical, we get our checkup and an EKG, just to see if we're going into these arrhythmias. And, I also have to mention, one of my passions, which is valvular heart disease. And as I said before, the valve degenerates as we age. And, oftentimes we can pick it up with the stethoscope, but sometimes we need more advanced imagings, echoes, like an echocardiogram or an ultrasound of the heart. But we have to kind of, especially in our 70s and our 80s, start to think about valvular heart disease. And that's oftentimes a reason for people to have shortness of breath, to not feel as well, or just to be more fatigued. So certainly the valves are something that we also have to address.
Okay. Really such great information. And this brings us to the end of our session. Dr. Basman, I want to thank you so much for sharing your expertise with us. And I want to thank all of our attendees who've tuned in for our second teleconference. I hope you all enjoyed it as much as I did. I want to remind everybody to please call in every month on the last Wednesday at 11 a.m. Going forward, the call-in number is going to change. I will send that out to all of you so you have that new call-in number. Okay, but next time on March 31st at 11 a.m., we're going to discuss prediabetes with Pat Talio. She's a registered dietitian and a certified diabetes educator at Northern Westchester Hospital, and we will do that in honor of National Nutrition Month. So thank you again, Dr. Basman.
Thank you for having me. Again, this has been a fantastic opportunity, and hope to do it again sometime soon.
We appreciate that. Thank you so much. Everybody be well.
Bye-bye.